Good evening, everyone. And it's my most pleasure to be part of the Cardiovascular Women Disease in Women virtual edition, second wave. The first wave was a huge success, which was actually earlier in February. And I'm extremely glad to share this webinar with outstanding speakers and cardiologists who will enrich this session. I will start with Dr. Michelle Albert, who is the immediate past president of the American Heart Association and is the Walter A. Haas Lucy Stern Endowed Chair of Cardiology and Professor in Medicine at the University of California and San Francisco. She's also the admission dean for the University of California, San Francisco Medical School and the director of the Nurture Center, which is Center for the Study of Adversity and Cardiovascular Disease. Dr. Michelle Albert, welcome on board. And my other... Welcome, Dr. Michelle, to this cardiovascular disease in women.
Thank you so much, Dr. Kadara. I am honored to be here and to participate in the second wave of cardiovascular disease in women webinar this morning. Should I go ahead and get started?
I would like to welcome Dr. Rasha just to, because to give the audience and the attendees an idea about all of us participating in this webinar. Dr. Rasha Al-Bawardi, an interventional cardiology consultant at King Faisal Cardiac Center and assistant professor at King Saud bin Abdulaziz University for Health Sciences. Welcome, Dr. Rasha Al-Bawardi, on at this cardiovascular disease in women, wave 2. I'm extremely excited when Rania told me that you will be able to join in person at this webinar.
Thank you so much for organizing this event and for inviting me to be part of it. It's my pleasure.
Sure. Dr. Albert, I think we are a couple of minutes late, and it will be great to really dive in the first talk, which I've been really looking forward to be part of this webinar, and especially that the topic that you will tackle today is the women leadership, and especially in the cardiovascular medicine. I look forward to listen and be part of the cardiovascular workforce with a focus in women and leadership in cardiomedicine. So please go ahead. There is, I have Dr. Rasha Al-Bawardi, and there are, because of the time arrangement, would you like to go ahead, Dr. Rasha Al-Bawardi, because Rania and her team is working on my slides. So please go ahead, and we'll start with your amazing and interesting topic to...
Thank you. Again, thank you so much for organizing this webinar, and it's really important to focus on cardiovascular disease in women. I really enjoyed Dr. Albert's talk, and we're going to shift. She set the stage really high, so apologies for the quality of the next presentation compared to hers. But we're going to move to a more clinical aspect of women heart disease, and in specific, the topic that was given is the management of antiplatelet post-PCI in women, looking into both risks and benefits. Can you see my screen? Okay. So before we jump into female-specific concerns as far as antiplatelet management, where I will talk about the guidelines first, and where are we, and then where is the issue, and how we can move on to the female-specific concerns. So what we know is that post-PCI, the whole idea of antiplatelet is that you want to prevent thrombosis, which come into two usually forms, stent thrombosis or even spontaneous MI. but also having 2 antiplatelets on board increases risk of bleeding. So it's sort of a kind of a tough balance between the two, because there are some risks to having thrombosis, and those risk factors can also be the same risk factors that increase your bleeding risks. So to balance between the two becomes more of an art of the matter more than the science, because we're lagging in terms of the science so far, and we'll go through the slides in a minute. So when we talk about the duration of DAPT post-PCI, it is really important to also come down to the indication of that PCI. So when we look at the guidelines, briefly, I'll mention both the European and the American. So the latest American guidelines come from the 2023 AHA and ACC. And as you can see in this diagram, if you have PCI in the setting of acute coronary syndrome, then the recommendation is to keep DAPT on for about a year. And this is pretty much consistent with also the European guidelines. However, and the DAPT here comes into aspirin plus another agent, and in the next couple of slides, we'll talk about other agents. But when it comes to stable angina, things become tricky, because we do have data to support the safety of shorter DAPT. And we also have data that says there is probably some population who are at increasing bleeding risk. So when you have a stable angina patient and you went ahead and did a PCI for that patient, then it's important for you to not only look at the duration as a default strategy, but also more of a individualized approach. So if someone has high bleeding risk, then your approach should be 1 to 3 months of DAPT. And then you de-escalate to one agent, preferably a P2Y12. In this case, should be clopidogrel, because it's a stable angina patient. And then after a year, switch to aspirin alone. When you have less of a bleeding risk and more of a concern of an ischemic risk, then DAPT should be ongoing for 6 months. And then from that forward, you should switch to aspirin for life. So what is the antiplatelet that we typically use? If it's post ACS, then we actually focus on using prasugrel or ticagrelor, compared to a clopidogrel, and it has a lower level of evidence compared to the other recommendations, but that has been a recommendation for using the DAPT and regimen post ACS PCI. And we already talked about those two recommendations in the previous slides. So what about the 2024 ESC guidelines? Is there any difference? When it comes to ACS, I think the regimen is still the same as far as duration. DAPT is still recommended for a year. But then the dilemma comes with stable angina patients. So when you have a stable angina patient and you stent them, the default strategy is again 6 months, but then you can see all this variation, and it comes to balancing both bleeding risk and ischemic risk. And I put down what they mean by ischemic risks in this case, and the bleeding risk is calculated by precise DAPT and ARC HBR scores. But when you look at ischemic risks, some of them are individualized based on anatomy and where the lesions are, and some of them on the results of your PCI. So sometimes it's tricky because you don't really have that data. So you know where the stents are, but you don't really have the exact data of someone coming in from a different place. So it becomes tricky to understand the exact ischemic risk. And here we're talking about general population, both males and females. So you can see that with high ischemic risk, you prefer to keep them on a longer 6 months as preferred. And sometimes you switch to clopidogrel to ticagrelor or prasugrel. And if they have high bleeding risk, then a shorter DAPT duration. So if I haven't confused it enough, I will manage to confuse you in the next couple of slides, because you would think it's going to be simple. So do we have data to suggest which one is driving more of our decision? Is it ischemia or bleeding in women? And unfortunately, it gets more confusing. So when we make that decision in general population, it's a bit tricky because you have to play it with all the risks and benefits of both. But when it comes to women, the data is lacking, and I'll tell you exactly what I mean by that. So it's this balance between ischemia and bleeding that we're trying to do. So when we look at ischemia, I'll mention the few trials that actually looked specifically into this. So this is data from 21 randomized PCI trials, and they've included 32,000 patients, a good number of women, 9,000, but then if you look at percentage-wise, it's actually about a quarter of those population. And just to keep in mind that those women who were recruited in these trials were older and they had higher comorbidities. So maybe they're not exactly the same population as the men in those trials. And what they found is that post-PCI, they actually have higher risk of cardiac death and ischemia-driven target lesion revascularization at 5 years, which was driven mostly by the target lesion revascularization, not necessarily the mortality. So there might be an ischemic risk that's higher in women. This is just a signal. But again, it could be just because the women in these trials were older and had higher comorbidities, and not necessarily the female gender is what's driving the results. There's also other data that comes from pool data from 6 randomized trials, and the same theme that although there are a large number of patients, but only about 30% were women. And if you look at 1-year follow-up, they're actually higher MACE in women, although they're smaller percentages in general, but they're actually higher in women compared to men. But this has not been consistent with subsequent trials. So this is data from a randomized trial. This randomized trial looked at patients post-PCI and randomized them to 2 different strategies of dual antiplatelet therapy. So either DAP for 1 month, followed by single antiplatelet, which was ticagrelor for 23 months, or adapt for 12 months, and then aspirin for 12 months, which is usually the standard of care. And as you can see, the same trend, 15,000 patients, but only about 23% were women. And this actually had a mixture of both, about 50% were stable angina and 50% were ACS patients. And in this analysis, they really did not find a difference in terms of all-cause mortality or MI or ischemic events in general. But what they found is that hemorrhagic stroke, as well as BARC3 or 5 bleeding, both were higher in women. So now we're not seeing a higher trend in ischemic events, but we're actually seeing higher trends of bleeding events. And when they looked specifically in the 2 regimens of antiplatelet, there wasn't really a difference if you used the ticagrelor arm or the standard of care arm. In both arms, there was actually an increase of hemorrhagic stroke as well as bleeding events. This bleeding risk or a tendency for higher bleeding was recurrent in multiple other trials. And most of these are just subgroup analysis of earlier presented trials. So it wasn't really designed to look at bleeding risk specifically in women, and it was just a post hoc analysis of these large trials. There was in one study a concern for 2-fold increase in bleeding events in women if they've used a more potent antiplatelets like ticagrelor and prasugrel. However, that did not really translate in other trials, and we'll show that in a second. And there's also a higher rates of major vascular access sites bleeding events in women. And not only the bleeding by itself, but if they looked at the bleeding events, they were actually associated with higher mortality. So it's not just morbidity that we're talking about, it's morbidity and mortality. This kind of raised a bit of a concern and led to a subsequent analysis because we do use prasugrel and ticagrelor in women, and the concern from an earlier study if there was a true 2-fold increase or not. So to answer that question, there was a bigger study with meta-analysis with a bigger sample size of 24,000 patients. And what they specifically looked at is that whether ticagrelor or prasugrel increased the risk of bleeding in women. And it ended up being actually, there's really no difference, statistical significant difference in terms of that between women and men when it comes to using those agents. So yes, it increased bleeding probably in both, but not necessarily in women versus men. So there are many other trials. Again, these are not designed for women. These are just retrospective kind of or subgroup analysis of earlier published trials. And some of them did kind of mention an increase. The ones that increase risk, increase ischemic events are the ones that I mentioned earlier, but majority of them did not really show an increase in ischemic events. So it could have been that the increased ischemic events that we saw in the 2 pooled analysis were actually related to just the higher risk patients cohort that they've recruited. The bleeding risk, though, is recurrent in multiple analyses, and it's not in just one. And it's really hard to make a definitive conclusion, but it has been repetitive in multiple analyses. But if you look at most of these data to kind of answer, hopefully answer that question, you can see that the women percentages in these trials were less than 30% at most, but less than 30% in most of these trials. So it's really hard to make a definitive conclusion as far as, do women really have a high bleeding risk or ischemic risk compared to men, and be able to answer that question definitively based on the data that we have. And to add to this confusing kind of questions that we have is that when we look at the differences, it's really how, where does it really stem? Is it biological difference in women versus men that actually we react differently or not? There are actually data to support that the high platelet activity that are proven in women, and these are just small studies, and it does come with more accentuated pro-inflammatory status. And there's also a direct link between estrogen, nitric oxide, which also affects platelet aggregation inhibition. So there might be some direct roles from hormones and down at the level of biological levels of platelet activity, but there might also be an indirect effect that we're seeing because some of these trials, when we look at women, they actually might have high prevalence of diabetes, and it's diabetes in this population that's driving some of these results, and not necessarily the sex-related difference specifically. So in summary, just to kind of recap of where we are right now, what we know so far is that women are underrepresented in major randomized trials, and we've seen that they're less than 30% in majority of major trials that looked into antiplatelet safety and efficacy post-PCI. So to make a definitive sex-based conclusion, it's going to be really hard, but what we've seen is that there might be a tendency for higher ischemic events, although not consistent. It was only in two main pooled analysis, and was mostly driven by the population that they studied with higher comorbidities. But the tendency for higher bleeding has been consistent in multiple analyses, and something to really be careful about. So far, we really don't have a clear data for the best combination of which antiplatelet to use. What we know is that prasugrel and ticagrelor have been shown to be same as clopidogrel when it comes to men versus women in terms of bleeding events. So really did not increase the events of bleeding. But there might be a benefit for de-escalation when possible, especially in those zones where you actually have stable angina, low ischemic risk, then you might be considering a de-escalation when you consider those more towards a high bleeding risk patients. So what we've learned so far is that it's actually medicine has become more of a personalized approach, and it's really not a one size fits all. And especially for women, it's not just a general woman, but maybe a premenopausal woman would be different than postmenopausal women. And what we need is really more focused data on that topic to be able to answer definitively. But probably a higher tendency for bleeding so far, so we have to be really careful with a prolonged doubt in this population. With that, I just like to conclude and thank you again for the great webinar.
To Russia, and it's actually a thought-provoking talk to think of whenever we are dealing with women versus men in managing with antiplatelets. Do you think with the interest and emergence of precision medicine, do you think that the platelet reactivity difference in women could be measured and accounted for?
I definitely think it will help, but unless we have large data from our own population, it would really be hard to answer that question specifically, because most of the guidelines are driven by large population, not necessarily just a one assay test. And that's really lacking. And if you think it's lacking in the US, it's actually worse probably in the Gulf region. So we're really behind. But what we've seen in actually in the TAVI registry in our population, that it's becoming consistent with the US that there's actually higher risk of access bleeding in women compared to men. So that bleeding theme, it keeps recurring in structural cases too. So I think there is a tendency, we don't really have a definitive kind of way of saying it, but we are seeing this repetitively. And I think most women, especially even radial access, has been shown to be a higher bleeding risk. I think most of them because they're elderly, they're thin. The way we approach them is the same as men, so maybe the TR band is not placed the same way, or so there are a few things that we do on a regular basis that might be actually different when you're approaching women, and especially elderly women.
We have as a panelist an interventional cardiologist, Dr. Zafar. Did you face the issue with antiplatelets in women versus men in the cohort patients, the large cohort patient that you have been dealing with?
Yeah, I think if we look at the complications, I think we find that the women tend to be more likely to run into issues, particularly with the dual antiplatelets, be it GI bleeding, be it stroke, be it a vascular access issue. Particularly the older they get and the lower the weight, we do know that this is associated with increased bleeding. We also know that the benefits you get from antiplatelets, when you showed that nice weighing the scales of ischemic burden versus bleeding risk, it's the bleeding risk that really determines what your outlook is going to be like. So it's the bleeding risk that determines which antiplatelet agents we use and how long we should continue with them for. You know, I know we always try to say, oh, it's a complex PCI, I use X number of stents, but it's rather than that being your driver as to determining which antiplatelet agents you use and how long you use them for. I think it's usually the flip, and it should really be, well, what's the risk of that person running into bleeding complications? And that will determine which antiplatelets I use and how long I use them for. And I think you've shown quite nicely that women are more likely to run into bleeding complications, but I think that tends to be forgotten. And you know, it's so easy to just go into automatic robot mode and say, here we go, just put them on dual antiplatelets for a year and be done with it. And you know, whatever the consequences are, the consequences there, we just don't think about it. But I really enjoyed your talk. Thanks very much.
Thank you, Dr. Zafar. Excellent point. And I think what highlights that we really get focused on the ischemic events because they also tend to be admitted under cardiology, and we see them. Unfortunately, when they have a hemorrhagic stroke or a GI bleeding, we tend to miss those, and they're really missed from our pool as far as complications from our procedures. And that's why we kind of focused on this and not that, because we're not really seeing the consequences of bleeding, as you mentioned.
Excellent point. The next question will be to both the intervention cardiologists who are on the panel today. I know Dr. Zafar has mentioned in a way what would be the bleeding risk, but what would be the thinking process managing a woman with acute coronary syndrome requiring a dual antiplatelet versus a man with acute coronary syndrome requiring a dual antiplatelet? Keeping in mind the risk of the bleeding and the risk of the bleeding in both.
I think the best way is to kind of follow the guidelines to assess bleeding risks. We tend to be really poor at that. So we tend to just say the default is 6 months for a stable angina. And we kind of miss that those patients are actually high bleeding risk. So if there is a way to incorporate those scores within your notes, if it's an electronic record or in their discharge summary or in the first visit after their PCI, then it might highlight that, you know, after 3 months, I should be actually careful and stop. I already have the data that it's actually safe to stop after 1 to 3 months for these patients. So I think highlighting just the bleeding risk by itself might help prevent some of those bleeding events that we're seeing.
Yeah, I completely agree with that. Absolutely. It's just really hard focusing on the bleeding risks and using that to determine how long you're going to keep them on antibiotic therapy for. And there are numerous scores out there, precise stat, I think what it is, which is really fairly simple. And that can give you an idea. But to be honest, a lot of these scores is common sense, really, isn't it? You see somebody who doesn't weigh a lot, who's elderly, you think, oh my God, she's going to have a bleeding complication. Do I really need a score to tell me that? it's just, if you don't think about it, you won't treat it. And I think that's the problem. I think this whole issue about stent thrombosis has been rammed down our throats for the last 5, 10, 15 years or whatever. That's all we're worried about, stent thrombosis. And oh my God, oh my God. But it's actually, it's the converse of that we really need to be focusing on. And that's even more so in females.
So what would be, because the initial management and the front line for to prescribe the dual antiplatelets are the specialists, the fellows, the residents who are on call during the on calls and so on, or they see the patient when they are coming for follow-up. So what would be the take-home message from managing prescribing dual antiplatelet with keeping gender as a concern or a parameter?
But I think it goes one step before that, really, doesn't it? I mean, we know with the I can't remember what the American guidelines are, but with the Europeans, they're quite keen on doing the angiogram first and then deciding whether you need to load them with dual antibiotic therapies or not. And we do know that women tend to have more inoka and anoka, so maybe they don't need to have such potent antiplatelet agents. You know, they come into hospital, they get the low molecular weight heparin, they get the aspirin, then they get their be it ticagrelor, prasugrel, or whichever other additional antiplatelet agent you have. And the question is, do they really need to have all of that
Yes.
as soon as they come into the door? Because we're just loading them with everything. Just, you know, we're asking for trouble really when a significant proportion of these patients probably don't need to have everything loaded at the front door. So I think maybe we do need to start taking a step back and individualizing treatment to the person in front of us rather than just one blanket and one size fits all.
I was going to say at our institution, we actually, unless somebody's, sort of really high risk and they got SD elevation MI or something like that, we actually don't load them. We actually take them to the cath lab first, and then make the decisions based on the cath lab, as you're saying with the European data and experience. I have two thoughts that I just want to throw out to you guys. The first is that on the pathophysiology aspect of this, the model of inflammation seems to permeate, through, sort of all of cardiology and all of cancer. With the increasing prevalence of obesity in our populations, there's the assumption that, sort of older women, sort of thinner, etc. But relatively speaking, sort of there's a climbing in terms of obesity. And in none of these trials do we see analysis based on necessarily, that aspect of the spectrum. And to that end, what do you think the interplay with SGLT2 inhibitors, could potentially be on this bleeding risk, both in the diabetics and the non-diabetics? And then the last point, that's a question, and the point, tying into the presentation I just gave, only 30% of people in these clinical trials tend to be women. It's usually, as you pointed out, Dr. Albawardi, somewhere between 15 to 30%. So that begs the issue of the leadership of the clinical trials, which tend to be largely men. And that's another issue topic for discussion that kind of drives even the hypothesis of clinical trials, like, what gets studied and who is in the trials.
Yeah, excellent points. I think
Well said, actually.
Yeah. For the first question, I think we're widely using dapagliflozin in almost all of our patients. I think with more data, HFpEF, with the HFrEF and all these patients that we're seeing and renal protective roles, we're really using the pretty widely. The concern that I have is that I've had 2 cases of ketoacidosis, and both in females. I know it's one of the side effects, and it's stated out there, but I just don't know if there's a way to predict those, because we just have to be careful that not throwing it for everyone in our department, but obviously within the clinical use of HFrEF and HFpEF, as well as renal protection. For your other question, exactly right, but it's kind of sad that we're still seeing less than 30% representation of women, and it's still not clear to me whether they're not being approached or the women themselves are actually declining to be part of the study, because it's really not clear from all these trials how many they tried to recruit and how many they've recruited exactly. Maybe you have more insight on that than I do, but what we're seeing is that less than 30% in most of these trials.
Yeah, I think part of it is related to the fact, and again, this extends to people of color across the globe, not just sort of only in the places that these cardiovascular trials tend to recruit, which tends to be Eastern Europe, right? Because the higher sort of prevalence of disease and the faster accumulation of the ability to get your outcomes. But I think that it has to be intentional. And we're having a discussion here about women and cardiovascular disease. We all care about this issue. So generally speaking, if we are the ones running these trials, et cetera, we would actually be paying attention to some of these issues up front. So I think that's one part of it. And I think the other part of it is that, certainly to extrapolate from data as it relates to diverse racial and ethnic groups and clinical trials, which is actually even worse than women in clinical trials, that we know that when people from diverse racial and ethnic groups get approached by physicians and researchers who look like them, they are more likely to consider and sign up for the clinical trials. So there's the issue of like the trust and who's doing what. So I think it gets back to this issue of ensuring that there's equitable distribution across like the demographic groups in these things. I always get really frustrated that I have presented at lots of sort of our national meetings. But the thing that always really frustrates me is when it comes to the late-breaking clinical trials and late-breaking sessions, they're exclusively presented by men and largely white men. And that is an issue.
Excellent point. I have to ask this question. Being 30% or less in those studies, do we think that this also in keeping with that women might be undertreated, under-recognized in ischemic in coronary artery disease management?
Yes, I think, I don't know if Dr. Albert is going to answer that, but we've seen this in multiple trials that actually they're usually treated later at a later stage. Many of these are missed and they're coming in with complications more. So yes, we've seen a recurrent theme of that. And even in SCAD population per se as well, is that when you look at SCAD, they tend to tell you that the presentation is usually ACS, but actually not necessarily it's ACS. It's because we're missing those who are actually having angina and pain, and we tend to kind of miss them until we do the whatever modality of testing that you're doing, cath or CT. But we are seeing recurrent theme of late diagnosis for these patients.
Yeah, there's no doubt about that these patients are misdiagnosed, underdiagnosed. I mean, I was quite pleased to see that with the latest chronic coronary syndrome guidelines from the Europeans, that they actually are starting to move away from the old classical definition of chest pain purely on exertion eased by rest to now actually including in their definition of a chronic coronary syndrome that it's not always precipitated by exertion and it's a syndrome per se. And it's not purely related to obstructive coronary artery disease, which the original guidelines stated. So, and a lot of these patients, they do present with microvascular angina. They have microvascular spasm, they'll get atypical pain, and the physician will just put it off because the pain can occur at any time and it's completely ignored. So they are mistreated, misdiagnosed, delayed diagnosis. And when I give my talk, there's actually a nice short study from Poland where they looked at patients, an extension of the EuroSpire study, and they looked at patients who presented with acute coronary syndrome, and females had higher total cholesterol, lower HDL, higher LDL over the age of 70, but they were less likely to be discharged on statins, and those who were discharged on statins were less likely to be discharged on high-intensity statins, and that's even when you do have the diagnosis. So they are undertreated and most definitely underrepresented in all of the clinical studies.
And I think to that end as well, the whole concept of typical and atypical angina, atypical chest pain, in the US, sort of the guidelines and perspectives have moved away from using the term atypical chest pain, because that's the category that women tended to fall into, in concert with your comments, Dr. Zahar and Dr. Abawardi.
So Ghadira, you got some slides up. Are you talking now?
Yes.
Excellent.
We are trying to fix the, I've been told to do and show other than. Apology for the delay. Just to present some background, I look after a patient with congenital and genetic heart disease, and part of my practice is dealing with cardiobstetric issues during pregnancies, and this is part of a multidisciplinary team at the cardiobstetric clinic in a tertiary maternal hospital here in Abu Dhabi. In the view of the whole dynamic changes during pregnancy, which extend to changes in cardiac output, heart rate, mean arterial pressure, stroke volume, and systemic vascular resistance, which drops during pregnancy. The pregnancy is a hemodynamic and cardiovascular continuous changes that has its significant impact on the physiologic and any pre-existing cardiac conditions in pregnant women. Starting with an ECG for a 44 years old and 30 weeks pregnant, this is the outcome of an IVF pregnancies presented with severe central chest pain. This is actually a patient who presented to one of our colleagues during an emergency department coverage. And if you notice, the ECG is consistent with ST elevation with reciprocal changes. The acute coronary syndrome during pregnancy is an unusual discussion in our morning reports and daily discussion, but when it happens, it carries a significant impact on recognizing the acute coronary syndrome, acknowledging it, and addressing it through a proper management pathway. This is a recent state-of-art review at the European Heart Journal, which was quoted by the American College of Cardiology, detailing the management of acute cardiovascular complication in a pregnancy. And the main concept of managing acute or non-acute cardiovascular issues in pregnancy is the concept of pregnancy heart team, which ideally should be involved early in the care of a pregnant woman, preferably in the pre-conception period, in the non-urgent issues. And presenting with acute cardiovascular complication or acute coronary syndrome will require a baseline evaluation, a pre-pregnancy status acknowledgement, and working through the WHO risk factor and evaluating if there was a pre-pregnancy counseling for any pre-existing cardiac issues. It's really vitally important to emphasize that it's a shared decision early involvement of multidisciplinary team, involvement of expert center or expert individual in the care, and to assess fetal status. Then to stream the patient, where would be the best site to look after this patient. We had a recent presentation of a patient with who was late, quite advanced in her pregnancy, and presented with an acute decompensated heart failure. Her echocardiogram showed a regional wall motion abnormalities, and she presented to a cardiac center without obstetric care. We had a multidisciplinary team with the obstetric and the anesthesia, and we decided to bring her to a center where obstetric, high-risk obstetric, cardiology, and intensive cardiac care unit is available for management and to deal with acute issues. It's extremely important to stabilize the patient. And that should not, and the patient is unstable, we should not delay any disease-specific treatment. And that's, be it a coronary angiogram or acute management with pharmacological lines. Diagnostic, we need to really be very well informed and to will educate the women about and to justify any radiation exposure, and really to be quite clear about what are the risks, because I believe in many centers and acute management centers and cardiac units and obstetric units, the risk is exaggerated for women who are requiring a radiation exposure. And all of us will know a patient or more who was delayed for an X-ray, delayed for an angiogram, and delayed for a CT scan because of the risk of the radiation is exaggerated. And there are quite well-defined risk of radiation that should be the reference in this case. The other aspect of caring of pregnant women is to plan and to evaluate what would be the delivery, and to evaluate the gestational age and potential benefit of early delivery if that's indicated. Always talk to the obstetrician and the anesthesia. Caring for those women, I find that there are 3 aspects, and I would say 4: the cardiologist, the obstetrician, the anesthesia, and the fetal. Quite important, it's not one person decision. Every one of us thinks it's his own or her own decision, but honestly, it's a multidisciplinary team decision. You need to hear from the fetal medicine the status of the fetus. You need to hear of the obstetrician what would be the best timing and method of delivery, anesthesia what would be the best choice of anesthesia, and the cardiologist assessment of the cardiac status at any point. We talked about transferring and looking after the patient in an environment where there is an expert, a multidisciplinary team. Look for red flags to prompt which method of delivery, and consider delivery in cardiac intensive care or environment where the cardiac intensive care is available. The most important objectives, although it says about the various presentation of acute coronary syndrome in pregnancy, I'll focus on the possible investigation management of acute coronary syndrome and some data about acute coronary syndrome in a pregnancy. The take-home message that I remind myself of, and I remind my junior colleagues, is that the management of acute coronary syndromes in pregnancy is similar to the general population. When we treat the pregnant women differently than the non-pregnant women, or differently than a man presenting with the same presentation, that's where the risk happens and complication and delay treatment decision happen. Fetal monitor, and don't forget the fetus. Just make sure that you have the fetal medicine and neonatal medicine on board. That's usually unusual team to be on board, especially for us, the cardiologists. We don't see them, we don't talk to them on daily basis, but they are very important to help you with the decision regarding the timing and the fetal distress. The indications, this is an important take-home message, the indications for acute revascularization are similar to non-pregnant patients with ACS. And if this is a gender themed session, I would say similar to every patient. One of our senior a team member in the cardiobstetric team mentions that they are similar to non-pregnant to all genders with ACS. So this is a take-home message that we need to keep and to prevent delay in managing patients. Rates of maternal acute coronary syndrome reported to be 0.6 to 10 per 100,000 pregnancies worldwide. The incidence is around 6% per 100,000 deliveries, with the mortality rate is between 5 and 11. In the mothers and reducing risk through audits and confidential inquiries across UK, this is a very important source of mortality, morbidity in women in UK. The cardiovascular diseases was the leading cause of maternal death, accounting for about 17% of all maternal death. And even with the updated data throughout, the cardiovascular disease is the leading cause of maternal death. And I believe that's the case also in the United States, and there is huge efforts to reduce the maternal death with cardiovascular disease in United States, especially with the recent data about the level, the increase in with the cardiovascular being the leading cause of maternal death. Ischemic heart disease, almost 1/5 of the cases. Pregnant women are 3 to 4 times more likely to suffer acute coronary syndrome when you age match them with non-pregnant women. And the incidence is rising. It's multifactorial. The rise is multifactorial, mostly because of there is increase in the maternal age, multiple comorbidities. Dr. Albert just mentioned the obesity and risk factors, the obesity, the metabolic syndromes, smoking, again, advanced maternal age. I have been doing the cardio-obstetric clinic with this team since 2017, and I have to tell you that there is quite an increase in women referred to the clinic where they are with advanced. Their major, one of the major factors are the advanced maternal age, the obesity, the bariatric surgeries, and the other metabolic profile quite predominant in those patients. As I mentioned, the management should be determined by an MDT compromising obstetrician, anesthetist, cardiologist, pediatrician, and do not forget the women, pregnant women who are coming with acute cardiovascular or acute coronary syndrome, or any other aspect of cardiovascular presentation during pregnancy should be part of the decision. And you'll be surprised to when you dig deeper in their choices of treatment or option or their rationale. When you face refusal from a woman for any treatment option during a management plan, make sure that you explain and you educate what are the fetal risks, because women tend to exaggerate the fetal risk and they would rather receive the risk of the delay of management rather than exposing the fetus to those risks. So just make sure that you discuss it in length and understand the rationale of some of the decisions. You should the care should be provided in an environment that really have all the skill, the facilities, the experts under one roof. The patient should be around a cardiac or obstetric intensive care. And that's for a monitor and anticipating and addressing any anticipated complication. When I mentioned about the management lines in acute coronary syndrome, as my colleagues has mentioned, and they were talking about the pharmacological therapy, percutaneous coronary intervention should be, which is the gold standard in acute coronary syndrome in non-pregnant women, should be really addressed quite early and discussed quite early in women presenting with acute coronary syndrome, because pregnancy is not a contraindication of PCI, and no woman should be denied a diagnostic angiography, and if needed, a subsequent intervention. This is a life-saving procedure and should be addressed early on with the experts and the multidisciplinary team that involved with that patient care. And I will, both of my colleagues, Dr. Rasha and Dr. Zafa, are interventional on the panel, and we will discuss that after the presentation. And I would be interested to hear their input in this regard. When acutely managing those patients, rapid assessment and liaison between all the decision makers and the teams that involve. Think about the timeline. Think, when should this patient be delivered, and if that delivery will affect the immediate management. Again, delivery should not delay. Management should not be based only around the time of the delivery. It's preferable to manage the acute coronary syndrome if the patient is stable, and address the delivery at a later point of time. If we are assuming that delivery is not imminent, you can start the treatment with a loading dose and any subsequent management that is required. There is an emerging evidence that clopidogrel is safe in pregnancy and would usually loaded as in acute coronary syndrome. The use of antiplatelet can be reviewed in the time of the angiography, as it was mentioned and discussed earlier, when decisions regarding stent requirement have been made, depending on the underlying etiology. Is it plaque rupture or more commonly coronary dissection? When we talk about managing those patients, you have to plan the delivery. In acute decision to deliver depends on several factors, always involve the obstetrician team. If it's an outside the extreme circumstances, immediate delivery would be rarely recommended. Delivery preferably delayed until at least several weeks have passed from the acute event. That will allow the woman to recover, and a reminder to our teams that delivery does not need to be undertaken before BCI. Address the acute cardiac issue first. The mode of the delivery determined by obstetric factors, and as I mentioned, it's a obstetrician, anesthetist, and the cardiologist. Remember that induction of labor is safe if the hemodynamic and the cardiac status is safe. There are some of the medication choice that you have to keep in mind that should not be used. Prostaglandin F analog, ergometrine should be avoided because of the vasoconstriction, which may affect both coronary and pulmonary, causing the right heart strain or even further myocardial ischemia. With the obstetrician and anesthetist, discuss the oxytocin use, and this is really to prevent any further bleedings. During delivery, the consideration to shorten the second stage by instrumental delivery is no longer recommended. So that will be really that's most of an obstetric management details, that they will help you to shorten the second stage and minimize pain, especially with the involvement of the anesthetist plan and management plan. This is really to emphasize that when you are dealing with a pregnant woman, you have to write down every aspect of the management, medications, first stage, second induction, second stage, what would be the best method of shortening this second stage, which doesn't need to be instrumental, and then post-delivery, and preparing for discharge and so on. So it's really quite a team to take care of this issue. Always, and this is something our anesthesia and ICU team reminded me when dealing with an acute condition, acute decompensated woman. When you are dealing with acute or severe cardiopulmonary shock or cardiac arrest in those patients present with acute coronary syndrome, resuscitation should take place with a left lateral tilt. And this is to relieve the aortocable compression. You will be surprised how hemodynamics are really changing supine to left lateral tilt. We had unfortunately, a recent patient who presented with hemodynamically significant pulmonary embolism and underwent a cesarean section in the emergency department. And one of the steps that the anesthesia and the obstetric team was to lateral tilt to relieve this compression. If in certain extreme circumstances, if it's over 24 weeks of gestation, perimortem cesarean section should be performed if there is no cardiac output and we could not reestablish within 4 minutes. Neonatal support should be really immediately available. After deliveries, we should really think about, before leaving the hospital, preconception counseling, planning the antenatal care, and to ensure safety of women and to educate them what are their options for future pregnancies. You should really pre-counsel and emphasize on women with pre-existing ischemic heart disease, history of acute coronary syndrome in previous pregnancy, residual cardiac function deficit, and all of those should be careful because there is an increased recurrence risk up to 10% with women with ischemic heart disease. And I believe there is a work from the cardio-obstetric team in the University of Toronto, the Candace Silversides and her colleagues, that more cardiac arrest happen on those patients with ischemic heart disease and a pregnancy. So we should be very careful when we are counseling those patients. Their cardiac function should be optimized and minimize any risk of decompensation during any subsequent pregnancy. There is lots of counseling about medication, the lipid-lowering medication, the antiplatelet, the functional status that will allow them to consider next pregnancy safely. Medication should be adjusted to really ensure no teratogenic drug and should be switched to suitable alternative. It's never too early to discuss contraception. I discussed contraception with my patient post-delivery, pre-discharge. And if the extremely high risk, we offer them a contraception really pre-discharge during the delivery of that pregnancy, because it's never too early. And you don't want to expose your patient to an increased risk of high-risk pregnancy, where you would be recommending to delay at least 12 months after an acute coronary event, even in women without evidence of continuing ischemia or residual cardiac function. The method of contraception is on the slides, and this is to remind you, or remind myself and remind everyone, that it's never too early to discuss the contraception during the pregnancy or post-delivery immediately before being discharged. I am very privileged to be part of a multidisciplinary cardio-obstetric team, and I always say it takes a village to look after a pregnant woman with cardiovascular condition. Thank you very much.
video on. I think it's important. You mentioned, you can't have a healthy baby without a healthy mother. And I think, all too often you see people come in pregnant mothers will have all sorts of symptoms. And they do require some form of radiological testing, be it to exclude a PE or be it to exclude coronary syndromes. And then, we hear these discussions, oh, she's pregnant, we can't do this scan, we can't do that scan, we can't do that scan. Well, if the patient deteriorates, well, it's too late, really. And then, you've missed the boat. So I think we do need to re-educate ourselves and our juniors that the priority really is the mother. And, we have to do what we have to do to try and get to an appropriate diagnosis. Obviously, there are things we can do to try and shield the fetus, but the priority is the mother. We have to, make sure we get the right diagnosis at the right time and not miss anything and just waste time.
Absolutely. If from your for our interventional cardiologists who are on the panel, what would be the first thing you will think if I pick up the phone, Dr. Zafar, and I refer a pregnant woman with clinical ECG markers suggestive of an acute coronary syndrome, be it ST elevation or non-ST elevation MI, what would be the checklist or the question that you will have in your mind?
To me, it's treat the patient. If she's come in and she's got chest pain, she's got ST elevation, she needs to go to the cath lab. End of story. I don't think there's any point. Why? She's all right. Fair enough. There is another person inside her, but as I say, a healthy mother is required for a healthy baby. So you have to treat the mother. She comes in, she has ST elevation, she's got to go to the cath lab. She comes in, she has chest pain, highly suggestive of a PE. She needs to go for some form of scanning to exclude or confirm a diagnosis of a pulmonary embolus. We have to confirm the SCAD, or we have to confirm whatever the most serious diagnosis is. I think the fact that she's pregnant, unfortunately, I don't know, I'm trying not to word this inappropriately, but we pay too much attention to that, and we kind of we move away from what is important, which is the patient in front of us.
Sure. I could not agree more, Dr. Zafar, on this. Dr. Rasha, is Dr. Rasha there?
I think she had to go to, she said she had another prior commitment she had to go to, unfortunately.
Dr. Michelle, what would be, do you have any data from your center where about the outcome in pregnant with acute coronary syndrome versus a non-pregnant women? Would that be something that has been discussed or elaborated on in your center?
Yeah, in terms of the center that I lead for study of adversity, that is not so much a topic area we focus on, but we do focus on a topic area that's related to what you just brought up, which is, I know the talk is on ACS and pregnancy. You did mention in your presentation that the elevated rates of maternal mortality. The United States has some of the highest rates of maternal mortality, and that's largely driven by cardiovascular disease, as you aptly noted. And then I think additionally, those rates of maternal mortality are elevated within Black and Native American women. And much of that is driven by a few issues. There's hypertension, which is the highly prevalent with resulting eclampsia and preeclampsia during pregnancy. There is also the issue of peripartum cardiomyopathy, which sort of also elevates the maternal mortality rates. And then there's the issue of bias in healthcare that contributes to the lack of treatment and diagnosis related to and not listening to the women's symptoms when they show up. So I think the ACS and pregnancy are really important issue, but additionally, the issue of prevention, primary prevention, prior to even a woman becoming pregnant in terms of treating her, risk factors for cardiovascular disease. And then also, and so educating the woman about that as she's thinking about becoming pregnant, and then the management of the complications as they arise during pregnancy. And then very importantly, I think post-pregnancy, the so-called fourth trimester,
Yes.
ensuring that the woman gets the adequate management for issues that have arisen during the pregnancy, and having, in our history for when we take care of women is actually acquiring a pregnancy related history as part of our cardiovascular risk assessment. So I just wanted to overlay that and add that to your conversation.
I'm very happy that you mentioned the fourth trimester, because this is something that we have been, I believe it has originated from issues with the insurance post delivery, but I think it's an important concept to promote to minimize the post delivery risk which happens in the period compromising or covered by the fourth trimester terminology. I'm very happy that you brought that up.
But thank you for great presentations.
Thank you. Any question from Dr. Zafar or any of the audience? I believe it's it's time for the focus insights into novel lipid management strategy by Dr. Zafar.
Yeah, thank you very much for that, Khadija. I'm just trying to find, where's it? Desktop. Okay, I'll do desktop. So I'm hoping you can see that. Excellent. Great comment. Great comment. Okay, fine. So first of all, thank you for the organizers asking me to talk about why lower LDL-C in patients with or at risk of ASCVD. And, I've given similar talks to this over the years. So I got back to thinking, when did I first become aware of lowering LDL-C was of benefit to the patients? I suppose it was the 4S study, and that was really published back in the mid-90s. And I can remember where I was when that got published. So that's over 30 years ago. Yet we're still talking about why lower LDL-C in patients with or at risk of ASCVD. So then I thought, well, actually, maybe we should rechange the name of the study. Oh, now I'm just technical issues. For some reason. To why we were still talking about this. I mean, the data's been there. It's robust data. It's data that's really very difficult to argue against. It's been there for over a quarter of a century. Yet we're still talking about lowering LDL-C. Just excuse me for a sec. My slide's having just a few issues. I'm not sure why. Can't go. Okay, that's better. So, as I said, the data is quite robust. It's very difficult to argue against. And I'm sure a lot of you have seen this from the CTT group, this slide, which has been there. It's been shown at many talks, many conferences, many meetings over the last 5, 10, 15, 20 odd years or so. And those, here we have studies in the grey triangle, primary prevention trials, and in the square blocks, the secondary prevention trials. And if you look at the y-axis on the left axis, that relates to secondary prevention, and on the right side, it relates to primary prevention. You get greater absolute reduction in secondary prevention trials. Why is that? Because they're at higher risk to start with, but the relative risk reduction is almost identical, whether it be primary prevention or secondary prevention. And all of these studies fall on this line. So, and we have studies now, Mendelian studies, which have been following patients up for 30 plus years or so. And what it's told us is that, you know, elevated LDL-C is no longer a risk factor for developing ASCVD. Yeah, so I'm stating the something different here. We always put dyslipidemia and elevated LDL-C as a risk factor for developing ASCVD. It's not. It is not a risk factor. Smoking is a risk factor for developing ASCVD. Smoking is a risk factor for developing lung cancer, because not everybody who smokes gets ASCVD or develops lung cancer, but you're more likely to develop it. LDL-C, elevated LDL-C, is a causative factor for ASCVD. If you have LDL-C and you have it elevated for a prolonged period of time, you will develop ASCVD. It is not a risk factor. It causes ASCVD. And that's all the more reason why we need to be more aggressive in lowering LDL-C cholesterol. And you can see here, it's not just how low we get it, it's how long we can keep it low. And you can actually calculate your total plaque burden by multiplying your LDL-C in milligrams by the number of years it's been elevated. And for every 1,250 years, your risk of MI doubles. So if we have somebody with an LDL-C of 80, they're going to reach this magic point of 5,000 by the time they're 60. So their risk of having an MI is 1%. But if your LDL-C is 200, you're going to develop that, you're going to end up at that same risk profile 20, 30, 40 years much earlier. And not only that, as I said, for every 1,250 increase in this total plaque burden, your risk of MI doubles. And it's a logarithmic risk. So when you go from 5 to 6,250, your risk goes from 1 to 2%. When you go from 6,250 to 7,500, it doesn't go up by 1%. It goes up by, it doubles. So it goes up by 2%. So once you've got to the 5,000 marker, your risk is 1%. Once you've doubled that 5,000 to 10,000, your risk has actually increased 16-fold. So it's a potent causative factor of developing coronary disease. And it's not how high it is, it's how long it stays that high. And again, if we look at these studies here, we know that if you can lower your LDL-C by 1 millimole, your risk of having an adverse event is reduced by around 20%. But if you can maintain that for a prolonged period of time, your risk of developing ASCVD can actually increase around 50, 55% over 40 years or so. And this is quite powerful. So what I do now is when I see patients in my clinic and I calculate their risk of developing ASCVD, the calculations now are actually really quite smart. If you can actually lower, you can actually show the patient what the risk of having an MI or stroke is if you lower the LDL by just 1 millimole or 2 millimoles, and they will see it in front of them. You can halve the risk by lowering LDL-C and keeping it low. So data from 26 randomized trials, and again, this is an old slide. This was published in 2010, yeah, quarter of a century ago. 15 years ago, my apologies. So for every 1 millimole reduction in LDL-C, your risk of developing a major vascular event is reduced by around 22%. So, and if you maintain it at that level, the longer you maintain it at that level, your risk is reduced even further. And it's really based on that robust data that the Europeans came up in 2019, okay, 5 years ago, where they changed their guidelines so that for patients with ASCVD or other high-risk conditions, LDL-C lowering therapy should be prescribed to achieve a 50% reduction in LDL-C and an LDL-C of less than 55 or less than 1.4. So there's 2 points here. The first is and. So it's whichever one is lower. And then the second point here is less than. So in other words, your target should be lower than 1.4. And, you know, I see patients in clinic where they've been prescribed different lipid-lowering therapies. They've got the L down to 1. And then the physician has taken back some of the therapies because it's below 1.4. And I think, and the only way to try and make patients understand is when I tell them that their target should be less than 1.4, what I tend to say to them is that if you're revising for a test or an exam, your target is to pass the exam. If the exam pass mark is 50%, getting 51%, you've passed the exam, but wouldn't you rather get 95%? So that 51% for passing the exam is 1.4, but we want to get it much lower than 1.4. And we know from intravascular imaging that the lower you get the LDL, once you get it down to about 1.5, 1.4, you actually get lipid plaque regression, reduction in lipid plaque volume, and you get regression of the plaque. So you actually get increase in luminal area. So you can actually reverse the disease that's been caused. We also know that by the lower you get the LDL, you actually cause the fibroatheromatous cap on top of the plaque to become thicker and less likely to rupture and cause an MI. So how good are we at treating patients and getting them to target levels? So this is data from before the 2019 guidelines came out. So this is data from Canada, and it's a registry of almost 28,000 patients who presented with an acute coronary syndrome. And if you look at the blue triangle here, the blue triangle is basically how many patients had their LDL-C, their lipids tested while in hospital. The green triangle is how many patients achieved an LDL target. And at that time, it was an LDL target of 1.8 or 70 milligrams per deciliter. And then the third one is this gray triangle, which is how many patients had their lipids tested 90 days after discharge. And this is year on year on year from 2012-13 to 2017-2018. And you can see that 1 in 5 patients who presented to hospital with acute coronary syndrome did not have their LDLs checked. And of that, when patients were seen in clinic 3 months after, almost 60% of patients, only 40% had their lipid panel checked again. So it's no wonder why we're not achieving a target. And that was a target of 1.8. So if we assume our target now is 1.4, then this level is going to be much, much lower. And this was the study I looked at to see, is there gender bias between males and females? So this was the Polar Aspire study. This was a Polish study and an extension of the Euro Aspire study. And they looked at patients who presented to hospital with acute coronary syndrome. And they looked to see if there's a difference between men and women. And there was. Women were likely to have more abnormal lipid panel profile. So they were likely to have higher total cholesterols. They were more likely to have lower HDLs. And over the age of 70, they tended to have a higher LDL compared to men. And despite having this abnormal lipid profile, they were, 1, less likely to be discharged on a statin. If they were discharged on a statin, they were less likely to be discharged on a high-intensity statin. And they were less likely to be on a high-intensity statin when seen in follow-up. And surprise, surprise, they were therefore less likely to reach target levels. So there is a gender bias in how patients are managed. So what's the key message from the first part of this talk? The key message is LDL-C lowering is an integral part of ASCD primary and secondary prevention. But unfortunately, many patients are unable to achieve this target therapy and unable to maintain this target therapy. So what can we do? So I think in order to understand how we can manage this, we really got to go back to basics and look at how is LDL-C regulated, and it tends to be regulated more by the receptors on the hepatocytes. And these receptors, what they tend to do is the LDL-C particle will bind to the LDL receptor. This whole complex then gets engulfed into the cytoplasm, and then the LDL particle is destroyed, and then we're left with an LDL receptor. And one of two things can happen to that LDL receptor. Either it can be recycled, so it goes back to the surface of the hepatocyte to bind to another LDL particle and therefore lower your LDL levels, or a certain protein can attach to the LDL receptor, and when it does attach to the LDL receptor, the PCSK9 protein, it causes that LDL receptor to be destroyed. So if we can somehow prevent this PCSK9 molecule either attaching to the receptor or actually being produced, then we should be able to recycle more and more of these LDL receptors and therefore be able to reduce your LDL cholesterol. So these are the most of the medications we have available to us. We have statins that prevent production of cholesterol synthesis, and because you get inhibition of cholesterol synthesis, we end up getting upregulation of the LDL receptor. Then we have these monoclonal antibodies that bind to this PCSK9 molecule to stop it binding to the LDL receptor to allow us to recycle the LDL receptors. And then we have ezetimibe, which blocks the NeuronPC type 1 receptor, so it stops you from absorbing cholesterol and therefore prevents you from transferring cholesterol to the liver, so that the liver has to produce more LDL receptors to absorb LDL particles from the bloodstream. Now, the problem we have with statins is that when we double the dose of a statin, we don't get the same LDL reduction. A lot of people think that if I get 30% LDL reduction on a moderate intensity statin, if I double the dose, I'll get an additional 30% LDL reduction. Unfortunately, I wish that was true, but it's not, because as the liver starts producing more LDL receptors because less cholesterol is being produced, it's actually producing more PCSK9 molecules as well. So although you get an increase in number of LDL receptors, you get an increase in number of the PCSK9 molecule. And as we said, the PCSK9 molecule attaches to the LDL receptor and it stops it from being recycled. So just by doubling the dose of statin therapy, you will only get an additional between 8 and 10% reduction in LDL cholesterol. So we have to think of other mechanisms or other molecules or treatments to allow us to be able to reduce that LDL level down to where we want it to be. We talked about statins, then we talked about these monoclonal antibodies. So what they'll do is they'll bind to this PCSK9 molecule to stop it from binding to the LDL receptor, and that will allow us to recycle the LDL receptor. And then we have a third treatment, which is really, can we stop the molecule from being made? In other words, can we stop the, can we destroy the messenger RNA so that it doesn't go to the Golgi apparatus to produce proteins? And this is really where inclisiran comes in. So we'll talk briefly about how does inclisiran work, but in order to understand how it works, we have to go back to medical school. So if we all agree that the DNA is the building block of everything, so all of the proteins that we make are all encoded by DNA. So what happens is RNA polymerase basically allows us to make a mirror copy of the DNA, the segment, the part of the protein that we want to make. The messenger RNA then becomes mature, and then this is then taken to the ribosome, where the ribosomal RNA then puts all the building blocks together, and it produces the protein that's required. So if we can somehow disrupt this, then the messenger RNA won't go to the ribosome, therefore the ribosome won't be able to make the PCSK9 molecule. And this is how inclisiran works. It works by disrupting or degrading this messenger RNA for the PCSK9 molecule, so you don't get so you get reduction in the amount of PCSK9 molecule that's actually generated. And it's actually quite a clever double-stranded RNA molecule. So you have a passenger strand, you have the guide strand, which is the intelligent part, and then you have this triple antenna known as a GalNAc conjugate. And what this does is this is very specific for the hepatocyte. So this binds to ASPG our receptor on the hepatocyte, and it engulfs the entire double-stranded RNA. And again, I'm just going to we'll skip through this one. So this is your inclisiran molecule, and this is your GalNAc receptor. It binds to this ASGPR receptor. So this whole molecule, inclisiran, then gets engulfed. The receptor comes off, and this ASPGR receptor goes back to the hepatocyte, ready to attach to another inclisiran molecule. And now we're left with the guide strand and the passenger strand. So what this guide strand and passenger strand do is it then is loaded onto what's called a RISC, an RNA-induced silencing complex. The passenger strand then goes off and is degraded, and this now targets the messenger RNA for the PCSK9 molecule. And the messenger RNA for the PCSK9 molecule comes out of the nucleus into the cytoplasm. This RISC complex then binds to this, and it basically degrades the messenger RNA for PCSK9 molecule, and that results in no production of the PCSK9 protein. And if you don't get production of the PCSK9 protein, it means that the LDL receptor can now be recycled, and recycled, then taking the LDLC out of the bloodstream. So as I said, this part here is what we're degrading. So we're stopping the cycle from this process to this process by destroying this messenger RNA. And this is a normal physiological phenomenon. And the guys that actually discovered this won the Nobel Prize for this, I think in about 2005, from MIT and Berkeley, I think they were, I forget their names. So then if we look at the inclisiran, the research protocol, so it's quite a robust protocol, phase 1, phase 2, and phase 3. Phase 1, we're really looking at in patients with hepatic function and renal function. Phase 2, we're in ASCVD and homozygous FH. And then phase 3, we're extension of some of these previous studies, but also looking at patients with heterozygous FH, ASCVD and risk equivalent. So 10 and 11 and 9 are probably the type of patients you're going to be seeing in your outpatient clinic or in your hospitals. So we're going to just focus really on around 9, 10, and 11. So heterozygous FH, ASCVD or risk equivalents. For those who had ASCVD, inclusion criteria was an LDL-C of more than 70 or more than 1.8. For those who were heterozygous FH or didn't have ASCVD or were risk equivalents, required an LDL-C of greater than 100 or more than 2.6 millimoles. And the treatment regime is 1 injection at day 1, a second injection at 90 days or 3 months, and then 6 monthly after that. So every day 27 and day 450 and so on and so forth. And the primary endpoints, we're looking at the LDL-C from baseline to 510 and also the LDL-C at day 90 to 510. So in other words, when the inclisiran molecule was starting to have an effect and you saw a drop in LDL-C, was that LDL-C persistently kept low. And then the secondary endpoints were absolute change in LDL-C, CHIME, and then we're looking at other markers of PCSK9 levels, ApoB and non-HDL-C. And what it showed was that there was a significant reduction compared to placebo of around between 52 and 54%, and it was sustained. So, as I said at the beginning, it's not just how low we can get your LDL-C, it's how long we can keep it low. And you want to see a nice level, steady line, and that has the greatest impact on your ASCVD, the atherosclerotic plaque. Were there any safety signals? Not really. It's been studied in 9, 10, 11, more than 3,500 patients. The reason for stopping the injection, there's no significant difference between the placebo and the inclisiran molecule. Most of the adverse events were really injection sites, and they were mild to moderate. So that was the dosing regime that we talked about. The inclisiran molecule is actually excreted via the kidneys, but it can still be given in patients with severe renal impairment. It can be given in patients on hemodialysis. And the reason for that is that triple antenna GalNAc molecule on part of the siRNA, the inclisiran, is very specific for the ASGPR receptor on hepatocytes, such that after 24 hours, the amount of inclisiran left in the bloodstream is significantly reduced. And after 48 hours, you cannot detect the drug in the bloodstream at all. So if a patient is on dialysis, all you need to have is a 48-hour gap from when you give the injection to when the dialysis takes place. So the studies have shown that it causes an effective and sustained reduction in LDL-C, and it is generally well tolerated, and it's used in a majority of patients as a complement to maximally tolerated statin therapy. However, there are some patients, particularly we have a few patients, which tend to be women, the ones that I've looked at, who tend to be intolerant of statins or unable to take statins or other lipid-lowering agents. What about the efficacy and safety? So this is really data that's going out to about 3 years of Orion 3, 9, 10, 11. So heterozygous FH, ASCVD, and ASCVD risk equivalents. 3 years treatment to just under 2,500 patients completed. And again, you can see that the target between 74 and 78% were able to achieve their target LDL goal. So it's shown that the drug itself remains efficacious over 3 years, and there's no suggestion of tolerance. 50%, there remained a persistent LDL reduction of around 50%. Again, adverse side effects, there were no new safety signals that were of concern, other than the ones we talked about earlier, which is really injection sites, mild to moderate. Now, we know from all of these studies that patients in studies tend to do much better than patients in the real world, such that even subjects taking placebo tend to do much better than patients not taking anything in the real world. So can we expect to see similar results? So I looked at the data from our institution, and this is just really, I just looked at data from the first LDL-C molecule prior to taking inclisiran, and then data at 90 days after they'd taken the inclisiran. And you can see the graph or the slope from LDL pre to LDL post is fairly similar. There were a few patients who had minimal effects. In fact, one patient had an increase in LDL-C, which I still don't understand. But there were a couple who had minimal change in LDL-C. And I looked at their LDL-C after the second injection. So that would have been 9 months after the first one. And after the second injection, they had a significant reduction in LDL-C of around 70 to 80%. So what did we have? We had a 55% reduction in mean LDL. That's almost identical to what was seen in all of the studies, between 52 and 53% reduction in LDL. So this is real life data, and you're able to completely mimic the results that were seen in the studies. So is there a difference between LDL reduction in men and women? So again, I thought we'd just have a quick look at this. And we separated the group to men taking the inclisiran and to females taking inclisiran. And there was a similar LDL reduction. Clearly, again, more were men, less were female. But there was a similar LDL reduction, such that we had a 57% LDL reduction in mean LDL in men and a 55% reduction in mean LDL in women. So there's no difference. Well, again, the numbers aren't great, not high, but there was no suggestion of a difference between male and female. What we did see again is this gender bias. So if we look at the baseline LDL-C for females was 3.87, the baseline LDL-C for males was 2.66. I think we've said already that there is definitely a bias between how men and women are treated, but the efficacy of the medication appears to be similar in both men and women. So again, if we look at another real world setting, so this was V-Initiate, and this really compared inclisiran to placebo in patients who were unable to achieve the LDL-C after taking maximum tolerated statin therapy, and it was a 12-month randomized open label study. And again, you see that 53% reduction in LDL-C, similar to what we got in our study, 55% reduction in LDL-C. 82% were able to achieve the LDL-C targets, whereas in the usual care, only 22% were able to achieve the LDL-C targets. And one of the issues we have with patients unable to achieve their targets is adherence to medication. I mean, patient will come into you and you ask them, are you taking your tablets? They'll say yes. And then you say, are you really taking your statins? And they say, well, and then you find out they're only taking it 50% of the time. So is there any advantage that we can get from inclisiran with regards to medication adherence? So this was a 12-month adherence data for inclisiran versus the other PCSK9 modulating therapy, the monoclonal antibodies. And I found out there were more patients were adherent to taking the inclisiran because it's twice yearly injection as opposed to taking an injection twice weekly. So 80% of patients that were able to achieve were considered to be fully adherent, as opposed to 56% of patients were felt to be adherent to medication. So on that note, I'm just going to say thank you very much for the invitation, and I'm more than happy to take any questions if you have any.
Excellent talk, Dr. Zafar, as usual. I just want you show the slide where the women started off with a higher LDL level. This is to address the response to the first dose of the medication. Was that during an acute coronary syndrome setting, or during a cardiac intensive care unit admission, or a much more elective basis?
So just from memory, most of the men who were on the inclisiran were taking it for secondary prevention. The majority of females were taking it for secondary prevention, but there were more females taking it for primary prevention. So I don't think, I don't recall there being any males taking inclisiran for primary prevention, but there were the females who were taking it were those who were unable to. I mean, there were, say, the numbers aren't high, but there were more patients who were intolerant of lipid-lowering therapies, or said to be intolerant of lipid-lowering therapies, according to the medical records, in the female group than there were in the male group. So that may be one of the reasons why their baseline LDL was higher. But the reduction you got was similar between 55 and 57% for the male and the females.
So Dr. Zafar, certainly the exploratory endpoints looking at major adverse cardiovascular events with inclisiran, give a signal that there could be, a reduction in cardiovascular events. But as we await the larger outcome trials, do you have any thoughts about sort of the impact in women versus men, given that we're talking about, cardiovascular disease in women here?
So I think well, as I speak, Klaus Ray, I get in contact with a lot, and I keep asking him, oh, a friend of mine has told me that their kid's got this LDL-C and they're only 20 years old. And he turns on to me, he says, Zaf, Mother Nature doesn't care how you lower your LDL-C, you'll have the same impact. So I'm sure from the cardiovascular outcome studies, they're going to be really quite positive and promising. I think with regards to, I'm glad we're having this discussion, because it's so obvious that women are just getting such a bad deal. And to be honest, I think a lot of it is to do with arrogance, male arrogance, that they don't think women suffer from cardiovascular disease. I think they think, oh, it's another woman, she's just complaining about this, that, and the other, and they don't get given appropriate treatments. I think with the inclisiran, I think anything that you only have to take twice a year can only be a benefit. There's no doubt about that. And I'm sure you have patients, and you sit down with them. You say, you're taking your tablets? They say, yes. And you say, are you really taking your tablets? Say, well, actually, I didn't take it this morning. Okay, so then how many of you not taken this week? Well, I haven't taken it 3 times this week. Okay, so you're only taking it half the time that you should be taking it. So I think with inclisiran, I think we'll see probably a greater benefit than we have done with some of the other medications.
And I think
Outside of the studies, because in the studies, everyone takes their medicines, but outside of the studies, not everybody takes their medicines. And, I think you may actually find that when you start looking at real world practice, the data may actually be better than what's published in the studies, because when you, I'm just trying to explain myself in the sense that in the studies, everyone takes the medicines because you've got somebody calling you up every 3 months or whatever. Whereas in real life, the group that aren't taking inclisiran aren't taking their medicines because they haven't got anybody hounding them. Whereas with inclisiran, you've got the injection, then you don't have to worry about it for 6 months. So
I think that's an interesting and important point. I mean, I think another question as a follow-up would be that, a lot of large outcome trials are powered to, show a 20-25% reduction in the usual care versus the intervention arm. And it's becoming harder and harder to show that, sort of 20 to 25% reduction. I'm just curious as well about, regardless of gender and all of these issues, your thoughts on that particular topic in trial versus, I get the point about outside of the study and the adherence, but just generally.
I think
on top of the statin and
yeah, exactly. I mean, you're right, exactly, because now you've got them on antiplatelets, you've got them on statins, you've got them on this, you've got them on that, you've got them on semaglutide, you've got them on dapagliflozin. You've dramatically reduced their baseline, call it baseline risk prior to being commenced on inclisiran. So that risk is significantly lower. So how big a study am I going to have to do in order to get that additional 20-25% lowering? And I think this is where those non-inferiority studies come in. And I understand why they're done, but I'm not a big fan of them. To be honest, they're quite complicated, and I have to really sit down and think, what am I reading when I go through these non-inferiority studies? But I think, to be honest, I think that's probably what we're going to see more and more and more of, particularly in cardiovascular outcomes, just because you're going to need tens of 20,000 patients in order to get that additional benefit that you do get. But I think once you've done that, I think what people end up doing is they'll start doing retrospective analyses of people that they've got in their database. And I think then you will see a significant difference.
Thank you.
Today's webinar was really thought-provoking and an eye-opener to many aspects of. First, as Dr. Michelle Albert has elaborated in women leadership in cardiovascular medicine, it's really with a great work that she shared with us. Dr. Rasha El-Bawardi, an interventional cardiologist from Saudi, who shared her presentation about dual antiplatelet, and Dr. Zafar input from an interventional cardiologist with the lipid lowering challenge that he's tackling and educating all of us about. Thank you very much. I will ask the audience if there is any question that we should be sharing before the closing remarks of this webinar. I don't have any question, but a great talk for everyone. And I hope that we can connect offline at some point to discuss some of those important issues. I'm very keen about the women leadership in cardiovascular medicine, and I really your presentation is an eye opener, Dr. Michelle Albert.
Absolutely.
Thank you, both Dr. Gadari and Dr. Zafar.
Have a nice evening, maybe a nice day there in California, and a nice
evening. We still have the rest of the day.
Yes, I can see the rays, the sun rays.
In the back, yeah. Thank you.
And have a great day.
Bye-bye.
Absolutely. Thanks very much.
Bye.